Hello everyone. In this video I would like to introduce you to the basics of the Next Accreditation System, or the NAS, of the ACGME, as well as to the milestones, which are an important component of the NAS. The old and new accreditation systems are quite different. In the last site visit in 2011, the Program Information Form, or PIF, was 119 pages long and took months to prepare. The infrequency of visits as well as the massive data collection that it entailed created an environment where programs would scramble to get everything together at the last minute and then be so exhausted at the end that they wouldn't have the energy to update or change anything about their curriculum or educational design after that until the next site visit was looming around the corner. This happened every 5 years. We also, at that time, were using an ACGME case log system that tracks the number of cases that the residents do, and that is still in use under the Next Accreditation System. In addition to the case log system data, which we upload on a 6-month basis, the ACGME will also be collecting milestones data. And I'll explain to you more what milestones are in a few minutes. Annually, the ACGME will collect information from our resident and faculty surveys, as well as scholarly activity reports from both the residents and the faculty, as well as board scores. If potential problems are noted by the ACGME, or if a program deteriorates, a focused site visit can be conducted at any time under the new system. Outside of that, however, site visits will move to every 10-year cycles. Most importantly, programs that are meeting their metrics will be freed up from the mundane constraints of generic program requirements and allowed to innovate, something that was definitely very difficult to do under the old system. So what is a milestone? Understanding this is the key to understanding the Next Accreditation System. A milestone can be many different things. It can be a knowledge, a skill, behavior, attitude, outcome, or some other attribute. It describes an accomplishment that a resident is expected to make by a particular point in their training. The milestones are organized numerically from less to more advanced, from the beginning of residency through to the end, like a developmental ladder. You're probably asking yourself, why are we shaking things up in such a drastic way? To sum it up in one word, accountability. There's no getting around it. Today things are moving in the direction of more and more accountability and outcomes measurements. The public, and therefore our government, are interested in knowing that we are competent and can be trusted to self-regulate. The ACGME and the ABR receive their mandate from the government to accredit residency training programs and certify individual physicians, and they use this mandate to enforce compliance with their policies. For example, in the future, the ABR could, if it wanted to, use milestones to determine access to take the certifying exam. But those things are more in the abstract. For us, the program directors and the residents, the milestones will be a tool to better assess you and provide you with more meaningful feedback, as well as giving us an ability to identify deficiencies earlier so that they can be remediated. Also, residents can look to the milestones as a blueprint to judge their personal progress, as well as to define their own personal aspirations. You are all by now more than familiar with the 6 core competencies as specified by the ACGME. Now these 6 core competencies have been broken down into 12 sub-competencies on which the milestones are based. Patient care and technical skills are now broken into PCTS1, consultant, and PCTS2, competence in procedures. Medical knowledge is broken into protocol selection and optimization of images, as well as interpretation of examinations. Professionalism, one thing still, professional values and ethics. Interpersonal and communicative skills are broken down into communication with families, patients, and caregivers in number 1, and in number 2, communication with members of the healthcare team. Systems-based practice is split into quality improvement and healthcare economics. Practice-based learning and improvement is split into PBL1, patient safety, PBL2, self-directed learning, and PBL3, scholarly activity. 8 of these subcompetencies will be evaluated every block with milestone-based questions, and these are the ones that are displayed in orange text. 4 of the milestones will be evaluated semi-annually using information shared between us in your meetings with the program directors, and those are highlighted in orange here. So what does a milestone look like? This example is PCTS1 consultant. You can see that there are 5 levels. These correspond roughly to what is expected of a radiology resident of that level. So for example, a 3rd-year radiology resident, a PGY4, is expected more or less to be at a level 3. So if you receive an evaluation score in the middle of the milestone, that means that the milestones in that level, as well as in the lower levels, have been substantially demonstrated, as demonstrated here. Selecting a box on the line in between the levels indicates that your evaluator thought that you had achieved the milestones in the lower levels as well as some milestones in the next level above. For this milestone, in order to achieve level 1 and beyond, a resident must be able to use evidence-based imaging guidelines such as ACR appropriateness criteria, and also must appropriately use the electronic healthcare record, the RIS and EPIC, to obtain relevant clinical information. From there, one should be able to recommend imaging of common conditions in level 2 and uncommon conditions in level 3. And these will need to be defined by each of the individual services in newly revised milestone-based goals and objectives to be done this year. For a level 4, a resident should be able to integrate current literature, guidelines, cost effectiveness, and risk-benefit analysis to recommend imaging. One should aspire in level 5 to eventually participate in research, development, and implementation of imaging guidelines. A general interpretation of milestone levels in radiology will be shown here. So at level 1, that resident demonstrates milestones expected of one who has had some education in diagnostic radiology, a first year. Level 2, you're advancing and demonstrating additional milestones. Level 3, you're continuing to advance and demonstrate additional milestones. The resident at this level consistently demonstrates the majority of milestones targeted for residency. In level 4, the resident has advanced so that he or she now substantially demonstrates the milestones targeted for residency. This level is designed as a graduation target, but at this time is not a graduation requirement. At level 5, the resident has advanced beyond performance targets set for residency and is now functioning at the level of someone who has been in practice for several years. It is expected that only a few exceptional residents will reach this level. Some additional thoughts. Again, level 4 is designed as a graduation target, but is not a requirement. And making decisions about readiness for graduation is the purview of the residency program director and the education committee. Study of milestone performance data will be required before the ACGME and its partners will be able to determine whether level 4 milestones as well as the milestones in the lower level, are in the appropriate level within the developmental framework. In other words, do these milestones make sense for diagnostic radiology? They haven't been used before. This is the first time they're being assigned and evaluated, i.e., this is a work in progress. So here's how it will work in practice. At the end of each rotation, you will receive an evaluation that is milestone based. The faculty will fill this out using their normal appraisal methods, such as your performance on service, and they may or may not decide to utilize additional evaluation tools such as online modules. Then, all of the end of rotation milestone evaluations will be aggregated together, and additional evaluation measures, either rotation assigned or program assigned, that may not have been captured in the original end of rotation evaluations will be factored in, and the final milestone assessment will be assigned by the Clinical Competency Committee. So the CCC will use your end of rotation evaluations plus any additional evaluation measures and assign you a final milestone assessment. And it will do this every 6 months, at which point the data will be transmitted electronically to the ACGME. So what are some of these possible additional evaluation tools that we may utilize? 360-degree evaluations have more emphasis placed upon them in the NAS. These can be from nurses, technologists, patients, and also from your peers. Conference attendance logs, self-assessment and reflections, your quality improvement project, research project, learning portfolio entries, procedure logs, your core exam results, ACR in-service exam results, completion of assigned modules or other educational tools, and participation in journal clubs